Hello and welcome to the Queen Elizabeth Patient Podcast, coming from the Proto Building in Gateshead. We'll have the wonderful Pauline Connelly today discussing neoadjuvant chemotherapy. Pauline's one of our resident breast care nurses and has a wealth of knowledge and experience when dealing with patients going through this treatment. So Pauline, thank you for coming today. Can you tell us a little bit about neoadjuvant chemotherapy? I know that's the posh way of saying it, but what does it actually mean?
Basically, Caroline, neo means before. If you think of your neonatal, it just means, when the baby's born a little bit early, the neo bit is before. So in breast cancer, we have recognised that some people do benefit from having their chemotherapy before their surgery. There's a couple of reasons for this. Mainly it's the biology of the cancer and the treatments available for those cancers. So often the decision is made in the MDT, which is our multidisciplinary team meeting, and the team, which includes the surgeons, oncologists, pathologists and radiologists, will discuss each individual lady, and at that point we should know if lady has a breast cancer and the markers on it, which include if a lady is estrogen positive or negative, and if a lady is HER2 positive or negative. And we know that certain factors increase the benefit of neoadjuvant chemo. There's also the size of the cancer does give an indication of whether the neoadjuvant chemotherapy would be beneficial as well. So there's quite a few factors we need to take into account before the decision is made. So the size of the cancer, if the cancer is over a certain size, and the surgeon feels that it would be difficult to operate and get a good closure, neoadjuvant chemotherapy may be beneficial at that point. So that is one of the aspects we would consider neoadjuvant, and one of the main reasons that neoadjuvant chemotherapy has increased in the last few years is the drugs we have available, and the fact that if we give them before surgery, we have found, and this is international evidence, that it can shrink down the cancer and it will help the surgeons perform surgery, but also can have a long-term benefit in reducing the risk of the cancer coming back. So there's certain cancers where if they're over a certain size, which is usually 20 millimetres, and they are HER2 positive, neoadjuvant chemotherapy is considered. So if the lady is fit and well, and they don't have any major contraindications, say such as a lady who has a poorly heart, and this may prevent the certain drugs being given. But obviously each patient will be spoken to by the individual doctor to see whether this is something we can consider.
It's a big decision, isn't it? And I suppose we're just there to help with the decision process and, give the patient as much information about, which is the best pathway for them. But ultimately it is up to the patient which way they would choose to go through. So once we've supported them through the decision and, the patient's quite happy to go ahead with having the chemotherapy first, what happens after that point when that decision's made, and what is the timeline? So I've been diagnosed with breast cancer, I've been told that I need chemotherapy first. When would I expect this to happen?
That decision's usually explained to the patient by the surgeon. So at that point, we then need to get a lady to see that oncologist.
And what is an oncologist? And what is the difference between an oncologist and a surgeon?
So your surgeon or the team member who will operate on you, and they take care of you long term and organise annual mammograms if you do not have chemotherapy. And if you have chemotherapy, we'll hand you over to our oncology doctors. So they are experts in chemotherapy, the drugs such as Septin, and some of them are also experts in radiotherapy. Now, our oncology team are all based in Newcastle and the NCCC. However, they are then go to the local hospitals and have clinics in their local hospitals where they organise the chemotherapy, because we do know that because chemotherapy is quite an intense drug, there are potentially lots of side effects. It is best to be at your local hospital. So if you do have a problem, you can go there.
So if I go to Gateshead, but I'm originally from Sunderland, I could have my chemotherapy at Sunderland.
Yes, so you would come to the Queen Elizabeth, or sometimes we have outreach clinics, say Grindon, which is in Sunderland, for your initial diagnosis. However, your surgery is always at the Queen Elizabeth Hospital, but the chemotherapy can be given at Sunderland, South Tyneside, Durham and the Queen Elizabeth Hospital.
Which would make it so much easier if I had a problem related to my chemotherapy, from a transport point of view. Because one of the things, I suppose, if you have got a problem with chemotherapy, it's important that you seek assistance fairly quickly. Would you agree with that?
So your local unit gives you the helpline, but it's very rare. But if you did have a problem where you woke up at 3 o'clock in the morning and you needed assistance, you don't want to be travelling miles to be helped. So the local hospital is the best hospital to receive your chemotherapy treatment.
When I'm starting on this chemotherapy, what kind of duration are we maybe looking at for the chemotherapy treatment?
So with your neoadjuvant chemotherapy, Caroline, depending on the marker, so if you're a HER2 positive lady, this means you're going to benefit from chemotherapy and the drug Herceptin and pertuzumab. So the ideal recommended chemotherapy is usually 8 cycles. In a cycle, it usually means 1 chemotherapy every 3 weeks. There are slight variances with this prescription depending on your individual medical health, your oncologist. So some ladies may end up having 1 chemotherapy per week for a longer period of time. It's the same drug but divided out in a smaller dose. So it is very individual, but the majority of ladies will receive 1 chemotherapy every 3 weeks, and it's usually 8 cycles. But if you have a slightly different kind of cancer, you may have 6 cycles. We do aim for those specified for your type of cancer. However, if a lady is struggling to cope with the treatment, the oncologist would keep close tabs on them, and you would also liaise with your chemotherapy unit if a lady was struggling, because there's some things we can do, such as reduce the dose. But if they continue to struggle, then sometimes the amount of chemotherapies they receive are reduced. We've got to get the benefit and the balance between how much benefit a lady receives from their chemotherapy to how much harm it's causing.
So I'm not very good with maths. I'm trying to work out, as a patient that's just been diagnosed with cancer and I'm having neoadjuvant chemotherapy, and I know I need surgery, and I've also been told that I'll probably need radiotherapy as well. How much time do you think, I would be thinking if I would need off work, or, I know it'll be like a ballpark figure, but, just to help with that kind of timeline, how much would you?
Because the intensity of the treatment, it can go on for a minimum of 6 months receiving the chemotherapy, but it's also the recovery. So neoadjuvant chemotherapy, you could have that chemotherapy for approximately 6 months. It can be slightly less, slightly more. And then you need to wait a minimum of 4 weeks once your chemotherapy has finished to have your surgery, and then recover from the surgery. And then if a lady needs to have radiotherapy, this is given a minimum of 4 weeks after she's recovered from her surgery. So it's a very intense form of treatment, but the way I kind of try and advise ladies to look at it, just say, kind of think of it as an investment in your life. So it's going to be a year of your life where you're either having treatment or recovering from treatment, but that is an investment in your future, and hopefully we will have the cancer removed to give you everything you need to help prevent it coming back, and then give you any other treatments you may need, such as, say, the tablets that you may take for 5 to 10 years.
So tablets after I've finished my chemotherapy and I'm waiting for my surgery, when would you envisage that I would possibly start taking any tablets such as tamoxifen or letrozole?
You would usually not start taking the tablets until about the time you start your radiotherapy.
Right, okay. I can imagine fatigue, tiredness is going to be quite a long haul, isn't it? So
yeah.
I think if anybody's worried about exercise and their diet throughout that sort of treatment, there's some podcasts that you'll be able to find in the unit that will help support that. But thank you so much, Pauline. I'm sure you've made it a lot clearer about what the path involves with neoadjuvant. Is there anything else?
No, thank you, Caroline. Obviously, we can't always discuss every single aspect of any treatment we give. So I would always recommend that you do contact your nurse specialist, and if they don't know the answer, they would try and find out or point you in the right direction.
And there's some great resources out there as well. What I personally would probably stick with is things like Macmillan and breast cancer care as well, which can be found online. And there is some further resources to help support with today's discussion. But thank you so much, Pauline, for coming today. You've been a great help. Thank you.
Take care. Thanks.